Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project Echo Session 6. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington. We're so excited for this Echo program to continue. So today for our agenda, we're really excited that Dr. Gail Bland-Newlundy will be discussing insulin and insulin titration in the setting of insulin-sparing agents, as well as Dr. McKenna will be presenting a complex diabetes and insulin case. And so now I'm going to ask the rest of the panelists to introduce themselves as they'll be helping to direct the discussion. So Dr. Gail Bland-Newlundy, please introduce yourself.
Well, good afternoon. I'm Dr. Gail Nunley Bland. I'm really stationed in Washington, D.C., so it's actually 3 o'clock my time, but I am an endocrinologist. We have a diabetes treatment center here, and I'm just delighted to be able to present for DECO.
Thank you. And Dr. Laura Montour?
Hi, everyone. I think we have met some of you before, but I'm a family doctor and obesity medicine specialist, and I'm the co-director for the Center for Weight Loss and Metabolic Surgery at UW. Again, I'm happy to be here.
And then Faiza Alibi?
Hi, everyone. I'm Faiza Alibi. I'm one of the clinical pharmacists at the UW Medicine Diabetes Institute and Lipid Clinic.
And then Dr. Emer McKenna. Did you want to say hi to everyone?
Hello, everyone. I'm Emer. I use they, them pronouns, and I'm a PCP over at Health Point Community Health Center. Thanks for having me.
So at this point, Gail, go ahead. Let's start our great lecture.
I'm going to talk to you about insulin titrations and using with replacement with insulin-sparing agents, our GLP and a GLP-1. I have no disclosures, and I will not discuss off-label use of medication. The objectives of this talk is to define the classes of insulin and the pharmacodynamics, explain insulin titration to achieve glycemic goals in type 2 diabetes, explain the use of insulin with insulin-sparing agents, identify diabetes technology tools to enhance diabetes control, use insurance formularies for prescribing diabetes medications, and use patient assistance programs for patients having problems with affording their diabetes medication. I'd like to just give you a little history regarding insulin. It's a little over 100 years ago that actually insulin was extracted from the pancreas of a dog for Banting and Best. Then McLeod and Collier actually improved the purity of the insulin, and actually Best and McLeod won the Nobel Prize in Medicine for discovery of insulin in 1922. Eli Lilly then subsequently began to manufacture it. And in 1922, the first patient to receive insulin showed that their blood sugars dropped tremendously from being very high to within the normal range. And then in 1978, that's when we got the genetic engineering of insulin. And this is the modern era of the insulins that we have right now. So let's talk about the insulin classes. We have the rapid, the short, the intermediate, the concentrated human regular insulin, long-acting, premixed, and the premixed GLP-1, and I'll go over each one of these. Let's start with the rapid-acting insulin. Lispro follow-on product. This is more of the generic form of Lispro. We have the Lispro, and then we have the Lispro AABC, which is the ultra-fast-acting Lispro, the glulisine, the aspart, and then the aspart fast-acting. And these are genetically, or I should say, pharmacologically modified insulins. And the terminology that is used now is the follow-on biologic insulin. And we have that for glargine and Lispro. And those are some of the ones that are the generic forms that may be a little less costly. And so they are similar to glargine and Lispro, but they're not the same. We have the biosimilar insulins, which have the same biologic and the pharmacokinetic property as glargine. And pharmacies can, based on insurance coverage, can substitute brand glargine without notification of the prescriber in certain areas or based on the insurance. Let's talk about the rapid-acting insulin pharmacodynamics. As you can see here, the Lispro and the aspart are within 23 minutes. They have their onset, peaks in within the 1 to 2 hours. Duration is 5, and the appearance is clear. Glulisine has a slightly earlier onset of action, and again, within 1 hour, it peaks. Duration 4 hours, and it's clear. The ultra fast-acting insulin, the aspart fast-acting, and the Lispro AABC Begins to start working in 16, 17 minutes. Again, peaks in 1 to 2 hours. Duration is begin to 4 to 5 hours, and again, it is clear. We have the Technosphere insulin, and this is the inhaled insulin, and it has a really fast onset of action within 5 minutes. It peaks in 15 minutes. It has a duration of 3 hours. It comes in a powder form. To use this insulin, you need to get the baseline FE before starting the patient on this type of insulin. And also, if the patient has COPD or uncontrolled asthma or smoker, this would not be a good choice for insulin. And in 6 months, you should check the FEV1 again, and then yearly. And if the FEV1 declines by 20%, then you should discontinue this insulin. We have the short-acting regular insulin. As you can see, the onset is on 1 hour as compared to the other ones where it was within 15 or 20 minutes. So it has an onset that is more delayed. It peaks in 2 to 4 hours, so it hangs around a little bit longer. The duration is 5 to 8 hours, and it is clear. And it has been associated with more hypoglycemia. We have intermediate acting NPH insulin. Again, the onset is 1 to 2 hours. It peaks in 4 to 10 hours. The duration is 14 hours. And this one is cloudy. And I always like to ask my patients, particularly if they've received the cloudy or the clear insulin, because sometimes in the mixed insulins, it gets confusing, or sometimes they're not. Pharmacists may have dispensed the wrong one, like the Humalog mixed types of insulin where it will be cloudy. And when you really want it, really the Lispro or Humalog insulin, which would be clear. Long-acting insulins are the Detamir, Glargine, Degludec, and the insulin Glargine-YFGN is our biosimilar insulin to Glargine. And our long-acting insulin pharmacodynamics include the Detamir has its onset within 3 to 4 hours, relatively flat. It doesn't have much of the, and it can last up to 20 to 24 hours, and its appearance is clear. Glargine has its onset of action in 1.5 hours. It's flat, has its duration of 24 hours, and it's clear. Gludec is one, has its in 9 hours, duration of 42 hours is clear. And the Glargine YGFN is exactly the same as the Glargine in terms of its pharmacodynamics. The insulin mixtures can be used, and oftentimes these are used when the complex insulin regimens where individuals may be injecting 4 injections a day. These are generally administered twice a day, and sometimes this may be the best form of insulin mixtures for those who cannot comply with complex insulin regimes. NPH and regular is a mixture of 70% NPH, 3% regular. And then we have the protamine Lispro, which is a 50-50 combination. Protamine Lispro 75-25 and protamine Aspart is 70-30%. And these insulins will be cloudy. And again, I've seen where they've been dispensed when you really wanted the Lispro, but you got the cloudy one. And that can sometimes cause complications with hypoglycemia. So I always like to ask my patients, what color is it? Is it clear or is it cloudy, to make sure that the right one was prescribed? And then these are the pharmacodynamics of insulin mixtures. Onsets are within 15 to 30 minutes. Peaks are anywhere from 30 minutes to 4 hours. And as you can see, the NPH in regular is an onset of 30 minutes. Peaks in 2 to 12 hours can last up to 24 hours. And all of these insulins are cloudy. And this one may have more hypoglycemia associated with it. So this is something that you should be aware of. Then we have our concentrated insulin. U500 regular insulin is 5 times more potent. Usually our insulins are U100, so it's 100 units per cc. And so we have also the U200, the 300s, the 200s of Lispro, and then the U200 of Lispro ultra fast acting. These often are used when large amounts of insulin doses are needed and the volume you're not going to administer as much. The U500 we tend to use in those who are severely insulin resistant, usually needing more than 200 units of insulin a day, and we may put them on the U500 regular insulin either twice a day or 3 times a day. And then we have our premixed insulin GLP-1s, receptor agonists, combination, where they have the largine and the exenatide, or the degludec and the liraglutide. And this may be useful in individuals who are on a GLP, but also on basal insulin. It would cut out one injection a week, so they wouldn't have to do the weekly GLP-1 injection. So this is a combination, which may be beneficial in someone who's going to have to do daily injections anyway. So when to use insulin? Well, of course, type 1 diabetes, they have to have insulin for survival. Gestational diabetes not meeting glycemic goals. Type 2 diabetes, if they're symptomatic with a blood glucose of greater than 300 milligrams percent, or if their A1C is greater than 10%, then insulin may be needed. Or if you're not reaching your glycemic goals despite maximally tolerated oral agents or non-insulin injectables. And then sometimes we have to check to see if this is immune-mediated diabetes, because despite, putting them on oral agents, non-insulin injectables, and they're still not meeting their goals, checking to see if they have diabetes antibodies. Glucocorticoids, and usually you need high doses of insulin, and sometimes using insulin such as NPH may be beneficial in this type of person, or severe stress from illness and progressive beta cell loss. So glycemic goals, we have to have an individualized approach to treating our patients. Not everyone should be targeted towards getting a hemoglobin A1C of less than 7 or 6.5. And you need to take into account whether their disease duration, if they've had long-standing diabetes, their life expectancy, if they have significant comorbidities that put them at increased risk for hypoglycemia or vascular complications. And also patient preference, or individuals who cannot comply with the complex insulin regimens that, the 4 shots a day or the carb cutting or whatever. So this is something that you need to take into account. Now, the other thing is insulopenia, looking at what the beta cell functions are, because the non-injectable agents, or the oral agents, non-insulin injectable agents, they work if you have endogenous insulin secretion. So checking for insulopenia may be something for when that patient is not responding to our treatments with these other agents. Medicare has defined their rule in terms of what they consider as insulopenia as having a C-peptide that is less than or equal to 110% of the lowest limit for the lab, with a simultaneous blood glucose of less than 225. Those were CMS guidelines. Or a glucagon-stimulated C-peptide that's less than 0.6 nanograms per ml, or as in the diabetes journal, Diabetes Care, they have mentioned that after 3 years with unclear classification of C-peptide measurement with concurrent glucose within 5 hours of eating is recommended. And then you can order a C-peptide. And if your C-peptide is less than 0.24 nanograms per ml, then this would be suggestive of insulopenia, and they have very little beta cell reserve, and that insulin probably would be needed in order to keep them under control. So many times we deal with clinical inertia in starting insulin. We have our patient barriers and our provider barriers. Patients, and I know I get this all the time if I need to start insulin, is that they're afraid of the injections, or they feel as though they know a relative, once they started insulin, they went on dialysis or amputations. But this is probably because they waited too late to start insulin or to get their diabetes under control. Weight gain is a fear that many people have in terms of starting insulin, as well as injection pain. Provider barriers, hypoglycemia, the patient resistance, lack of confidence in the patient's ability to manage insulin therapy, lack of integrated care, and uncertainty regarding insulin type, the complexity to be managed in a PCP's office. So it's not easy to really try to start someone in an office if you have a busy practice. And this is some of those barriers that providers speak of. A basal insulin titration. Now, the American Diabetes Association has put out this guideline, and I'll just walk through because it's very difficult to see this particular slide. But of course, lifestyle is top on the list, diet, exercise, meeting with a diabetes specialist, educator, is what is needed in terms of, successful treating of individuals with diabetes. But then you need to take into their clinical picture. If they have atherosclerotic cardiovascular disease, if they have chronic kidney disease, if they have heart failure, or weight is a condition that you need to be concerned about. Starting these medications that we have available in terms of using your GLP-1s or your GLP-1 GIPs in terms of atherosclerotic cardiovascular disease, your SGLT2s can be used in these conditions. If they have heart failure, then starting with the SGLT2s, and if they're still not under control, you can always move to the other agents. And then also in terms of weight, considering in terms of weight gain, if obesity, then maybe GLP or GLP, GIP may be your first line that you would use. And then your chronic kidney disease, SGLT2s and GLP-1s and GIPs can be used. And up to eGFR of 20, you can use your SGLT2s. And then, of course, looking at them again and reassessing. So how do we do pharmacological approaches to glycemic treatment? So first thing is to empower the patient, be a barrier buster. And then you can schedule diabetes-only visits, as it does take a lot of time to actually treat diabetes. Optimize care and treatment. Conduct practice-based screening for likely therapeutic inertia. Make personalized diabetes care plans. Those are things. And then leverage the tools and technology. Follow diabetes treatment algorithms is some of the things that can be done to improve glycemic control in patients with diabetes. So the question is, which therapy should I start first? Well, many times we can start with a GLP-1 receptor agonist or a GIP, GLP-1 receptor agonist before insulin therapy is started. You can always start with metformin as a first line. That is not unless it's a contraindication. And then when should I start insulin first? If there's evidence of catabolism, such as weight loss, blood glucose is greater than 300, A1C is greater than 10%, then you need to consider maybe using insulin. And this may be that patient who is newly diagnosed with diabetes, with significant glucose toxicity, and you need to control their blood glucose. And then gradually you can actually try to wean them off of the insulins when you start adding the other agents such as metformin, your GLP-1s, your SGLT2 inhibitors. The question is, can I use a combination of insulin and non-insulin injectable therapy? Yes, you can use those two. And commonly we do that in terms of if they were started on insulin, then we will also, it may add a GLP-1 and then we gradually taper the insulin off. Vice versa, if we start them on a GLP-1, but we have to add insulin, then, or if they were on insulin, we can reduce their insulin as well. And then consider the combination of these GLP-1s with individualized goals for the patient. And then when should you modify the therapy? Depending on what their blood glucose levels are, whether they're hyper or they're not at goal, or if they're becoming hypoglycemic, we would adjust that. And I'll go into that. So first thing is, if your patient comes to you, they're overweight, you should reinforce weight management through diet and exercise. Then if injectable therapy is needed to reduce their A1C, consider a GLP-1 receptor agonist in most patients prior to insulin. And then you titrate up. If a GLP is already on or a GIP is already on, then of course, if you're not getting them under control, then you, or it's not preferred, then you can add basal insulin. And we start off with 0.1 to 0.2 units per kg of long-acting insulin or bedtime NPH as our starting dose for if we add insulin. Now, what we try to do is have our target fasting blood glucose between 80 and 130, and then adjust if they have significant comorbidities. So if they have significant chronic kidney disease, where they're more prone to hypoglycemia, then maybe not targeting it to 80 to 130, but maybe 100 to 150 may be your target. And then you can do forced titrations, the fasting blood glucose after starting your basal insulin. If they're in the target range of 80 to 130, then keep them at that basal insulin. If they're between 130 to 159, you can add 2 units, 160 to 189, 4, 190 to 226, and then over to 28 units. Now, do not increase your basal insulin by more than 0.5 units per kg per day. If you reach that, then you need to start adding prandial insulin. And then, of course, if their blood glucose is dropping less than 80, then you need to reduce your basal insulin by 2 to 4 units until you get them into the target range. Now, with the basal insulin forced titration algorithm, sometimes you can give them rapid-acting insulin or short-acting insulin if their blood glucoses are out of range, particularly during the time of day. So at breakfast time, if it's between 150 to 200, you can give them 2 units. Try not to give them bedtime insulin because they may become hypoglycemic, but 201 to 250. So every 50 you go up, you need 1 to 2 units of rapid-acting insulin or short-acting insulin to get them under the target range. And this is a forced titration for your basal insulin with rapid-acting insulin. What about prandial insulin titration? So after you have tried to titrate them to, and you're at 0.5 units per kilo per day of basal insulin, then it's time to look at your prandial insulin. So you can add one rapid-acting insulin with the largest meal of the day. You can start with that, and there are protocols that go over that. You can either start 4 units, or you can do 0.1 unit per kilo per day, or 10% of the basal dose. And it all depends. And, when I have a very small person or one that doesn't weigh as much, adding automatically 4 units may be too much. And then maybe using your weight-based insulin may be a better choice, or using 10% of the basal dose as you adjust. And you can do this, adjust this every 2 to 3 days to get your blood glucose down in terms of the target range. Now, this is an algorithm for adding or intensifying insulin. This is with ACE, and they give you guidelines in terms of starting basal insulin. If their A1C is less than 8%, then using the total daily dose of 0.2 to 0.2 units, 0.1 to 0.2 units per kg per day of your basal insulin. If your A1C is greater than 8%, then the total daily dose can be a little bit higher, starting basal insulin of 0.2 to 0.3 units per kilo per day. And then you can titrate every 2 to 3 days based on what the blood glucose is. And again, once you reach that 0.5 and they're not at target range, then you have to add. Either you can add a GLP-1 or a SGLT2, or prandial insulin would be needed. And before we even add the prandial insulin, we would probably add our GLP-1s or SGLT2s, or possibly a DPP-4. So how do we add prandial insulin? Again, these are 2 guidelines that have been put out by organizations in terms of the ADA, as well as the American Association of Clinical Endocrinologists. And they're pretty much similar. I talked about the 4 units or the 0.1 unit per kilo or the 10% basal dose if the A1C is less than 8%, and adjusting every 1 to 2 units or 10 to 15% or once or twice a week. And then based on the ACE guidelines, begin prandial insulin before largest meal at 10% of basal dose or 5 units. And again, I would caution you with starting out with the 5 units because again, if the total daily dose happens to be maybe 40 units, then, and if you automatically give them 5 units, that may be too much. So, 10% of the basal dose may be a good starting point to make those adjustments. And again, titrating every 2 to 3 days and making the adjustments as needed. But sometimes we have to do basal bolus insulin. So you've started with the largest meal of the day. You find that the blood glucoses are still elevated midday or at breakfast time, then we may need to go on to basal bolus insulin regimens. And so with that, generally it's about a 50-50 ratio with 50% of your total daily dose is basal and the other 50% is prandial, divided into 3 doses. And the total daily dose for that can be anywhere from 0.3 to 0.5 units per kilo per day. And then you titrate again every 2 to 3 days to reach your glycemic goals and adjusting. And then, of course, if their blood glucose is less, you adjust your total daily dose down by 10 to 20%. Or if it's less than 40, you make 20 to 40% reduction in your insulin dose. And then what about NPH? And NPH is a relatively inexpensive form of insulin. There are regimens out on how do you manage using that. So you can start with twice daily NPH regimens. So you can start with 80% of your bedtime insulin being NPH, where you would get 2/3 given in the morning and 1/3 given in the evening. Or you can consider the self-mixed split insulin regimens, either NPH with short or rapid-acting insulin separately. And then 80% of the total NPH would be 2/3 in the morning before breakfast and 1/3 before dinner. And then you can add 4 units or 10% of the reduced NPH dose as rapid-acting insulin. And then also you can consider the twice daily pre-mixed insulin regimens where you give 2/3 of the before breakfast and 1/3 before dinner and adjust based on the individualized goals. The downside of the pre-mixed insulin is you don't have as much flexibility in adjusting for that prandial coverage that would be needed. I tend to use a lot more weight-based and carb counting, carb ratios, and correction algorithms as part of my regimen. And depending on the individual patient, if it's someone who's frail, got a lot of comorbidities, I might start off with 0.3 units per kilo per day as my total daily dose, and giving, if I'm going to do basal bolus, half as it is basal, or on the other half as prandial, divided into 3 different doses. I also often use a rule of 500 to help me calculate the insulin to carb ratio so that whatever their total daily dose, I divide it into 500. And that gives me how many units of insulin I need to give per gram of carbs that the patient would consume. And then I calculate the insulin sensitivity factor using the rule of 1800. And again, dividing the total daily dose to reach my target correction of 100 before meals. And this tends to be what I tend to use a lot more. If I started off with an example of a person who weighs 100 kilograms, and I started with 0.5 units per kilo per day, that would be 50 units. Okay, the basal insulin would be 25 units. And then if I calculate my insulin to carb ratio, the total daily dose would be 50 units, and 15 to 5 units, they need 1 unit for every 10 grams of carbs that they consume. My insulin sensitivity factor would be the 50 divided into 1800, which would be 36. So 1 unit would drop them 36 units. And you can just maybe round it to maybe 30 or whatever, or maybe 3 units per 100 that you want to correct the patient to. And then you can also use this formula where blood glucose minus the target blood glucose. So if they happen to be 200 and you want to get them to 100 and you divide it by the insulin sensitivity factor, that would be 2.7 units. So either it'll be approximately 2 units would be added to your insulin to carb ratio to maintain that target blood glucose level. And so this is something that I commonly use in terms of managing patients with insulin. So what do you do if you need to de-intensify the insulin and diabetes medication regimens? So if the patient has already started insulin, prandial insulin, and you start them on a GLP-1, you want to try to reduce your prandial insulin by 30 to 40%, or in some instances, maybe even discontinue it when you start your GLP-1 receptor agonist. And then if you have the patient just on basal insulin, you may want to decrease it by 20% when starting a GLP-1 receptor agonist if the A1C is less than 8, and 10% if the A1C is greater than 8. And then you should consider decreasing or discontinue your sulfonylureas or your DPP-4s and maintain your metformins, your SGLT2 inhibitors, and GLP-1 receptor agonists, or your dual GIP and GLP-1 receptor agonists as you're de-intensifying these complex insulin diabetes medication regimens. So also we can use these digital health tools that can help in terms of managing these patients. These connected pen devices that are available, and those are useful for patients that may not want to use an insulin pump, but it has factored into that insulin to carb ratio, the insulin sensitivity factor, your target blood glucoses that I had talked about, and they would put in their carbs into their phone, this app, and then it would tell them how much insulin to deliver. So I have some patients that really like this particular method. They're not connected to an insulin pump, and they use these pens that help them to administer the correct amount of insulin. And then the CGM devices, they have revolutionized how we manage our patients. Really, we probably have missed a lot of hypoglycemias that we didn't know about, or even hyperglycemias that we were just trying to figure out where we would start to manage our patients. And so we talk about the real-time CGMs, which really measures and displays the glucose levels continuously. And then we have your intermittently scanned CGMs, where you have to measure the glucose by tapping or swiping the reader on the device or with your smartphone. And then the professional CGMs are useful for individuals who, one, may not be able to get the CGMs with their insurance, but in the office, you have these professional CGMs that Medicare does pay for, and also some of the Medicaid plans pay for commercial insurances, where they wear the CGM device blinded for a week or 2 weeks. They bring the device back, and then generally we upload that data, and we can look what the trends have been, and they keep a detailed diary log of their foods that they've eaten. And then, of course, these standard AGP reports are very helpful with our goal of trying to get most patients within that 70% ideal glucose range of 70 to 180, I'm sorry. Less than 5% should be low, and then less than 25% should be high or elevated. So these are the things that was very helpful in terms of assessing, moving our patients to the target goals that we would like. Now, diabetes medications cost a lot of money. And even though we have these guidelines out here, sometimes you may have some challenges with patients who can't afford these medications, or their insurances will not cover them or whatever. And so we need to be cognizant of these insulin, non-insulin, as well as insulin costs. As you can see, sulfonylureas are probably the cheapest ones that we can use, TGDs. And as you go down the line, looking at the ones that oftentimes that are highly recommended, such as SGLT2s, you can see that the cost per 30-day supply can be anywhere from $408 to $718. The GLP-1s can be $964 to $1340. And then some of the other ones, bromocriptine, we don't use a lot of, but our dual GIP, GLP-1 receptor agonist, $1,200, and pramlintide, don't use a lot of that, but that can be upwards to $2,866. And so this sometimes can be a barrier of really implementing some of these guidelines that are being put out. Let's look at the insulin cost. Long-acting insulin, and this was updated from Diabetes Care guidelines that was put out in January, that the long-acting insulin, $86, that do Gludac, and the glargine pens in terms of 100 regular NP8. And then the most expensive one is the inhaled insulin, which can run $1,500 per month for 1,000 units. That's what I should say, because it all depends on how many units the patient does have to administer. Diabetes supplies. Where I am, I'm in Washington, D.C. at Howard University, and we have an uninsured population that sometimes get admitted to the hospital. And, we're trying to keep those costs down. And what I have found that, maybe going to Walmart's or to Amazon to get some of these diabetes supplies so that when you discharge them from the hospital, they can take care of themselves and, getting a cheaper meter, the lancet devices, the syringes, pen needles, and so forth. And so looking at from Walmart, it was about $92.23. And then, of course, at Amazon, it was a little bit more, but $113 for a month's supply of these, except for you can take the glucometer out. But this is costly in that we have to take that into account with our patients as well. And then we have our patient assistance program, and you have to make sense of them as well. So patient assistance program eligibility, if they have no private insurance, if they have no Medicaid, any of these, you have to have a proof of income, whether they have Medicare and they receive Part D benefits, they may qualify for low income subsidy. And then now we have those $35 insulin cards that can be used as well. It also depends on the insurances. Sometimes they let them use the, commercial insurance, sometimes they don't. But this has been very helpful in getting patients the insulins that they need. And then the private insurance copay assistance card. You can actually go online for those who have commercial insurance, and it can help with reducing their copays on their insulin or medications that they need in terms of managing their diabetes. And then I have a list of what I consider the ones that you can go online and to find these various patient assistance programs by manufacturers. The Lily's Care is where you can go and get that $35 copay, $35 card to get your insulin. And they really cover a large number of those insulins that can be beneficial to the patient. Sanofi has it, NovoCare has them as well. And so these are some of the things that you can look into to help patients who need assistance, these saving cards. And then the Medicaid formularies. It often helps to know if they have state insurance, what is covered on those formularies. So you do not write the prescription that is not covered, and then the patient goes to the pharmacy and can't get the medication. So I always like to make sure that I know what is covered on these particular formularies so that I can make sure that I prescribe what is available so that that can help that patient in terms of not missing any doses or not getting the medication that is needed. And then these prescribing apps can be very helpful as well. Coverage search, looking up the commercial insurance, what state they're in, fingertip drug coverage, and then formulary medical are all helpful in terms of trying to figure out which medication is covered by these various plans.
Thank you so much, Gail, for that great presentation. So great to highlight the different ways of initiating insulin and using insulin-sparing injectables. And then finally, the cost savings that we can help support our patients to getting access to these things. We are short on time. So what I also just want to highlight is I think you do sort of what I do, which is weight-based management of insulin. And that's one of the big points that I want to highlight. Always choose your insulin for a reason. Even if you end up choosing 10 units, have a reason and a calculation in your mind. And for someone who's resistant, 0.2 to 0.3 units per kilogram of basal insulin is a great starting dose, especially if the A1C is greater than 8. And then the other one question I just had for Gail is, I find when we start prandial insulin, I don't love to keep them at 0.5 units per kilogram. I tend to de-escalate to 0.3 and then potentially start my prandial insulin at the 2 largest meals and maybe do about 0.2 units rather than the starting of 4 to 5. And again, this helps individualize it. I was wondering what you felt. I have a feeling you probably think sort of the same.
Again, it depends on, I look at and the patient is really insulin resistant, I may use that 0.5, but if they're not, or you see that they're relatively sensitive or they've got a lot of comorbidities, then I will use just only the 0.2, units of prandial insulin to start off with.
Yeah.
So you really have to individualize your patient.
This is the hard point. And someone's just asking about if the A1C is 8.5 and you're starting GLP-1, do you de-escalate? And I would say, if you believe they're taking their insulin, perhaps yes or no, based on if you believe they're consistently taking it, right? And I always give people just a ability to rapidly taper it down. Like I'll say every time you go up on the dose, or if you're having sugars in the low 100s, go down by 5 units, because we can always re-increase the insulin. So I'm going to now turn it over to Emer. Go ahead and start your great case. We're going to share the slides.
This is the case of a patient who is a 66-year-old Amharic-speaking woman who moved to the state of Washington in September from Oklahoma from Ethiopia via a few months in Oklahoma. She always comes to her visits with her daughter, who's a CNA, and this is a really great supportive factor for her healthcare. Her daughter manages a lot of her meds, helps her with injections, and helps her with like food and lifestyle stuff as well. So when I first met her, she was injecting 42 units morning and 32 units night of Novolin, and she was prescribed 12 units BID of Humalog on a sliding scale before meals. She was also on glipizide, omeprazole for chronic GERD, and her A1C when she established was 9.6. She had had diabetes diagnosed 16 years ago in Ethiopia. She'd been managed with insulin for 5 years, and when she first established, she didn't have any insurance at all. So we re-prescribed the medications that she was already on. They were getting a lot of things sorted out, and they had also been trying to make a lot of lifestyle changes. Part of the reason for the move from Oklahoma was because it was really hard to find traditional ingredients for Ethiopian foods. And so it was hard for her to be on her traditional diet, and she switched more to a standard American diet. And they noted that diabetes control worsened at that time. So she came to stay with this daughter versus another relative in Washington instead of Oklahoma. The next time I saw them in November, she had Medicaid, and we started trying to get her a CGM. And I started her on a couple of other meds. In the next time that I saw them was February 2024, and they had stopped the mealtime insulin because she was checking her blood sugar on finger stick, and her fasting blood sugar was always within range. Her A1C was still really elevated, and they later stopped glipizide. When I was doing this case review, this kind of like deep dive back into this patient's case in 2 separate EMRs, I did notice a pattern that hadn't fully coalesced for me, where they tend to sort of go on and off different medicines without a super clear reason why not. So that's something that is on my mind now to pay more attention to. So in March, late February, March, we started being able to get records from the CGM regularly. And at that time, they started seeing the RN about every 2 to 4 weeks for sensor change and insulin titration and data download. The RNs here are great and asked if we could start Vigerion. This was initiated and titrated and then self-discontinued at some point for a reason that I don't know why. Looking at the CGM tracings at the beginning, it showed that the GMI was better than the A1C, but there's pretty significant postprandial hyperglycemia after every single time she ate, and then big drops of blood glucose from bedtime to the next morning, making me think that the basal insulin dose was a bit high. The CGM had a secondary effect that we didn't really anticipate, which was the patient paid very close attention to it and started being really reactive to any time she would see her blood glucose dropping after a meal. And so she started changing her eating habits and eating like fruits and drinking juice and drinking milk and having date shakes throughout the day. And so we started to see a little bit of a reactive worsening of her glycemic control. And then, we started working on some of that. She had stopped prandial insulin for a while in there. I think I mentioned that, and started trying to down titrate the basal insulin and up titrate the postprandial insulin. And so we are, I think her blood sugar is starting to get a bit better controlled, but it's definitely been somewhat of a journey. So her problem list includes diabetes type 2 without complication. She does have glaucoma, which is managed by ophthalmology. I did a DEXA on her after she got insurance, and she has osteoporosis, for which we started alendronate. She has seen GI for the chronic GERD without esophagitis based on endoscopy. And then I have discussed with her a couple of times, would you be willing to retry metformin? So she was given metformin in Ethiopia. It was stopped due to creatinine increase per patient, and she was told that she should never take it again. And she is very strongly will not be trialing metformin ever again. We don't know much about her family medical history or her personal medical history. And I think, her social history is non-contributory. She doesn't drink. She's never smoked. And you can see there some of the discordance between, this is the most recent labs due for annual labs here in a few months.
I just wanted to ask one clarifying question before we start the case notes and discussion. What I noticed with their tracings and will show is, she has these postprandial peaks, like they said, but then she has this great decline overnight. Did you ever ask her specifically, because her fastings are normal in the morning, did she not take her NPH in the morning, but then she would be high by the evening, but only take her NPH in the evening, or what she did when she had normal blood sugars with her insulin?
When she had the normal blood sugars, she would stop taking, like she stopped the glipizide because of that. She stopped the prandial insulin because of that. And then there was some up titration of basal to try to, like get the A1C lower by RN. And yeah, that was mostly what she would do. She said that she did always take her AM and PM doses of the NPH insulin, but sometimes got nervous about the nighttime dosing of it. So it's possible that she didn't do the nighttime dose, but wasn't able to tell or wasn't willing to tell me that. But I don't think that really tracks with the tracing. And then you saw, I think, that I did change to glargine from the NPH at one point. They were wishing for less injections and also would feel less nervous about the basal insulin if it was just a morning injection. So that was part of why we did that.
Great, that's great information. And so let's go ahead and talk a little bit about this case. So as we sort of know, this is a 66-year-old female with type 2 diabetes for 16 years and insulin-dependent diabetes for over 5. She does have some reflux, and then also she has osteoporosis and glaucoma. When you initially met her, she was on NPH 42 units in the morning and 32 in the evening, and she was taking Humalog twice a day with her meals. She was additionally on glipizide, and she was using a PPI omeprazole to sort of mitigate her GERD symptoms. She was uncontrolled and she had no health insurance, but then she did get Medicaid insurance. And so we were able to give her some diabetes tools, which is great, the CGM. And then at the same time, SGLT2 inhibitors were added, particularly, I believe you said it was empagliflozin. And she also had some cardiovascular risk mitigated with atorvastatin, which was great. And the other thing I will highlight is my understanding, what you told me, is that her daughter is a CNA and so has some background in health and so can be a support to her diabetes management. You also had great support from your nursing staff, so you were able to do more frequent visits to titrate things. What is less clear is that she was on Bydureon. We're not sure why she had to hold it, but it did allow her to decrease some of her insulin initially. And then she started to have these, or she ongoingly had hypoglycemic events, which then led to her to change her eating habits to really mitigate those falls in glucose. And so her most current therapies that she's on now are appropriately de-escalation of the basal insulin. So she's on glargine at 34 units, empagliflozin at 25 milligrams, and she's on Lispro that has been appropriately titrated up to 10 to 11 units at breakfast and lunch, and then a lower dose at dinner, and none with the bedtime snack. But you had said that she still had some concerns about hypoglycemia. I guess my question here is, on this dosing, was she still concerned about was this the last tracing that you gave me that we'll look at?
It's not the very last tracing. The last one I didn't have. It disappeared somehow in the EMR switch. But yeah, it's a recent one. It's from mid-September, I think. And then what was your other question?
Oh,
Sorry.
just that if you feel like she was more confident and wasn't having to eat all the time with this newer regimen, or she still felt like she was doing a similar eating pattern despite you de-escalating the long-acting insulin.
So I do think that she has improved. And part of it, I think she was having reactivity not only to hypoglycemia, but just to watching her blood sugar fall on the CGM. So she would see it start to come down after a meal and then get really nervous and be like, oh my God, what if I go hypo? I should start like drinking milk all throughout the rest of the day,
Got it. So it wasn't actually the absolute going below 70, it was that rapid change of blood sugar that she was seeing.
That was a lot of it. And she had some true hypos, but only a few, maybe one per tracing. And all the tracings that I sent you didn't actually have any.
Yes, correct. And so, we always want to ask ourselves because it helps us decide our best therapies if she produces insulin or not. For the sake of time, I'm just going to say, yes, it appears she's probably producing her own insulin, but we always want to think about it if their control worsens, when we're trying to replace insulin with other agents. And then our second question, so I think she highlights that because of her high risk for hypoglycemia, because of some of the medications she's on, until we can introduce insulin sparing agents and reduce her insulin requirements, we probably want to aim for a 7.5 to 8 A1C goal. And then the third question that we were sort of talking about and you raised is, does her CGM data match with her A1C? And sometimes it's hard, right? Because it's a 3-month average for the A1C versus if she's responding or increasing or decreasing her insulin based on what she's immediately seeing with the CGM, that's like the last month. So they may not match just because it's a more recent change, but you can see here there was over a 1% difference in the A1C versus the GMI on her first set of labs. And, my thought process is I would, given her history of GERD, is just screen her for iron deficiency anemia. Even with a normal CBC, we can definitely see low iron levels. And so that can falsely elevate the A1C and cause us to chase after and add more insulin in the setting of, sugar control that is actually at goal. And then B12 deficiency also can falsely elevate the A1C. So I would probably screen her for those two things, but what we want to say here is what you can see here is this very rapid decline in blood glucose overnight. She's on a pretty significant units of NPH at 32 units. And then if she really is taking the Novolog, she then is having, escaping from that Novolog 12 units twice a day with meals. And it is interesting. If she was just on it twice a day, you can see these peaks 3 times a day. They're almost equal. So I just question if because of her fear, she was taking that dose of insulin. And then your clinical question, and I think it's a great one, is sometimes too much information may be not good for the patient, even though knowledge is power. And so how do we utilize CGM to best support the patient without increasing her anxiety? And so we always start with non-pharm, and I think this is the crux of things that, we want to address her fear of hypoglycemia or even that relative change in glucose. And we want to teach her how insulin works and really make her understand that we're thoughtfully selecting a dose of insulin based on what her body's doing and what we're seeing on the CGM. And then I think we need to continue to support her misinformation about medications, because if we can use non-insulin medications, we're going to use less insulin and reduce her risk for low blood sugars and also sort of those rapid changes in blood sugars. And then we want to teach her little skill sets so she understands how to best interpret her diabetes on the CGM. So, I'm going to call on Dr. Montour, our obesity expert here. It always starts with nutrition. So very briefly, I'm going to ask her if you could tell her one thing to work on from a nutrition standpoint, what would it be? And how do you think it would affect her blood sugars and support her?
Yeah, I think mitigating hypoglycemia in particular, it's very important to, I think, layer the protein through the day. But also looking at this example here, you can see the bagel with butter, it causes that peak of about 186 compared to a piece of ham and cheese, about 146 peak. So having, high quality complex carbs is definitely important, but I'd say also potentially eating the protein first before the carb.
Yeah. And so we have to be careful of the absolute calorie intake, but having that quality protein first before the first bite of carbs, it may keep her from having that relative peak. And then she might not have quite as rapid of drop. And that might be one way that's non-insulin to support her. Now I'm going to call on Faiza, our pharmacist, just to talk about NPH and this increased risk of hypoglycemia because of the physiology of this type of intermediate to longer acting insulin.
So, as Dr. Earhart mentioned, one of the biggest things we can do to empower our patient is really to educate her on how her insulin works so that she's not afraid to take it for normal or lower sugars. The basal insulin that she was previously on, NPH, is an intermediate acting insulin, and you can kind of see the kinetics of NPH and how it compares to other insulins. It starts working in about 1 to 2 hours. The peak effect happens around the 6 hour mark, and it lasts anywhere from 12 to 20 hours. Some of this is really dose dependent. But because of that peak effect, we often like to give the evening dose at bedtime so that the peak coincides with the rise in sugars that we often see in the early morning due to a dawn phenomenon. If you give the dose with dinner, you might be seeing that peak late at night, and that could be putting the patient at risk for hypoglycemia. Although, for some patients, it might be easier to remember to take a dose at dinner time than at bedtime.
Those are all great points. And I think the one thing I usually stress with people is when you have a normal blood sugar, your background or basal insulin, so your intermediate or long-acting insulin, doesn't even take effect for an hour or two, and it shouldn't drop your blood sugar. We want to pick the right dose of insulin for that background insulin or the basal insulin so that it just maintains your blood sugar. And then we also sort of highlight with our prandial or rapid acting insulins that it does take typically 15 minutes to start to see the effect. And so if we don't take it until we start to see the rise, we're actually not going to match the physiology. And I suspect this might be what the patient is doing. They are waiting until they see a rise of blood sugar, and then it's not, the onset is too late, so they get a much higher thing. And I think, supporting that understanding will be great for her and help her not have such a rise and then have that relative change as well. And now I'm going to ask Gail, when you're converting NPH to glargine, tell our group how you go about doing that if they're on twice-a-day dosing of NPH.
So I usually give 80% of whatever my NPH dose is when I'm converting it to glargine. And so we're moving from a twice a day to a once a day. And this can help to prevent the hypoglycemia that may occur if you give it as a 1-to-1 ratio.
Great points there. And, the other thing is I think we already all highlighted that you do not want to have too many potential hypoglycemic agents. So when someone is on prandial insulin, you want to make sure they are not on sulfonylureas, because then you've got the pancreas being flogged to produce insulin and you're giving exogenous insulin. And so we really want to make sure that you do not use sulfonylureas in the setting of prandial or mealtime insulin. And then number two, I do use glimepiride and glipizide occasionally in the setting of basal insulin, but again, we have to make sure the basal insulin dose is appropriate, and I typically will only use a moderate dose of sulfonylureas, not a higher dose of that medication. And it sounds like you've already had multiple discussions with the patient about metformin, but this is one of the most common things that we tend to hear from our patients, that metformin hurts the kidneys. And so I think maybe if you go about saying, we want to use this medication because it's going to make you more responsive to your insulin, maybe get you off of insulin, it would be one of the agents we could use to replace insulin with, and it does not hurt the kidneys. We only can't use it if the diabetes hurts the kidneys. And your kidney function has been great. And there's even newer information saying that even people with kidney dysfunction from their diabetes can use it, but at a reduced rate. Now, I definitely have seen people who don't want to retry it because of what other doctors have given them information about, but I do think maybe in the setting of saying this is one medication that will be a great tool that will not cause you to have hypoglycemia, and our goal is to get you off of insulin, and we think this is one of the tools that will get you off of insulin, right? And again, we want to be utilizing those medications that have low hypoglycemia risk, and this will be based on, cost for patient and availability. But this idea of using a GLP-1 receptor agonist or a GIP GLP-1 receptor agonist initially before we start insulin, if it is available for the patient. And we sort of talked about it. We want to choose a weight-based dose. So this is how I'd go about this patient. I would say she's having hypoglycemia, or she doesn't have hypoglycemia, but she has fear of hypoglycemia and she's feeding her insulin to maintain her blood sugar. So what dose do I feel comfortable with starting her on based on her fears, and which I believe will not cause low blood sugars. She does not have kidney dysfunction and she's fairly insulin resistant. But right now, if you looked at her initial dosing, she was on 1.2 units per kilogram per day, and about 70 of them were long-acting insulin. So she was on over 0.5 units per kilograms a day of the long-acting insulin. And so, you know, we're using NPH here in case we have to use it because she doesn't have access to other medications, if she doesn't have insurance again, right? And I would reset her to no more than 0.2 to 0.3 units of NPH insulin per day. And I would use the 2/3 in the morning and the 1/3 at bedtime. And that should be a very safe dose for her. And at most, I would go up to 0.4 units for the total dose of NPH. And again, you know, it doesn't last 24 hours. So it's probably somewhere between 0.25 to 0.3 units, right? And we're doing only a third of it in the evening. So again, this is where she has fear, and this is how we reduce it. Now, if she told me that she was scared to take insulin at night, I'd also be comfortable just getting rid of that NPH in the evening as a starting spot. And then she can see that rise. And if she decides then as a paired partnership, we should add a little bit of insulin at bedtime, I would be very comfortable with that. And then I actually think she probably needs 10 to 12 units of prandial insulin, or even more based on her nutritional intake and what we're seeing on the CGMs, but I'm just not confident she's taking it on a regular basis. So in this particular case, I would ask her, what dose of insulin would you be comfortable taking with every meal? And if it was 4 or 5 units, I'd be very comfortable with that as a starting dose. If she said 2 units, I would say, let's start there, and then we can watch your tracing. So it's really, we want to make sure the patient's taking it consistently, and that's the starting point because we can always go up on it. And then the other teaching point is we just want to make sure there's first no low blood sugars. Even if we suddenly are seeing sugars of 300, I'd be very happy if she wasn't having those changes, and then we can slowly titrate it. And then, you know, the other question is what medications would be available if she did not have insurance that would be cost effective. And Gail already highlighted our Walmart having, you know, our $4 and $10 medications. You know, in her case, because the CGM is teaching her so much, I would say if we could get her on metformin and even just like 1 milligram of glimepiride, she could see how she does on that. And I wonder with that CGM information if she would do behavior modification to improve her blood sugars. You know, again, the glimepiride does put her at risk for low blood sugar, but, you know, it seems like she's fairly insulin resistant. So more than likely that may not be enough medication. So, you know, I really believe metformin and a little bit of NPH with a little bit of prandial insulin is probably the best way to go for her if she does not have insurance and access to our more expensive medications. But again, I would pick one or the other, and I might actually preferentially just put metformin with 5 units of prandial insulin so that she doesn't have any risk, real risk for low blood sugars, and then go from there. And the final thing is even though it's not weight neutral and an increased rate, insulin can cause weight increase. So, you know, we could try metformin, glimepiride, and 15 milligrams of pioglitazone and see how she does for a month to 6 weeks, giving that pioglitazone time for effect and her behavior modifications with the CGM. And she may have good control with those 3 oral agents, because if she's at 9, each one drops her about 1 point, she makes it to her goal, right? So these are all things to consider. There's no wrong answer. And remember, it's a marathon rather than a sprint. And I'd much rather see her average sugars be 250 with not tons of rapid changes, so that then she has a starting space to go from. And so you can sort of see here, the main thing is the NPH at bedtime. I think what I see is that, you know, she has this steep decline overnight. And, you know, it continues, even it looks like if they did, I think this is, even though this was written as 36 in the morning and 24 in the evening, this was the most recent one. So I think this was on just the glargine at 36, and you can still see a decline overnight with it. So again, I would reset even the glargine to no more than 15 to 20 units at a time as a starting spot, and then have her watch her CGM, and then whatever dose of the mealtime insulin she was interested in. And this is her final tracing. This is what they were saying is that, because she was eating all the time, even though they had increased the prandial and decreased the glargine, she still was having worsening control because of her fears and her continuous eating. So there's something called,
Nicole, I can clarify, sorry. The July one, she was still on NPH, and the
okay,
September one, she was on glycogen.
on glargine. So she wasn't, so that's great. So the glargine at 34 or 36 units is about 0.38 units per kilogram. So I'd be very comfortable keeping her on that dose, but I don't know if she's comfortable with it. So that would be the first question that I would ask. And, basically what we wanted to highlight is when you see a drop of more than 50 points overnight from the basal insulin, it probably is an indication they may need prandial insulin or, to reduce that basal insulin and add an insulin alternative. So, and there's just multiple points about not over basaling people. And you'll hear me say this probably once a lecture because it's probably the most common thing we see. It's easy for the patients, but it's not the most physiologic. And even on our patients who have a lot of insulin resistance, there isn't a lot of added benefit to go over 0.5 units per kilogram. And so we sort of talked about this, titrating insulin. I like just using 2 units very easily between 80 and 130. But in people with hypoglycemia, I usually just titrate their basal insulin to average blood sugars fasting of 140 to 150 as a starting spot. Because sometimes if they have a higher fasting blood sugar, they're more likely to take that prandial insulin because they're not scared of their normal blood sugar in the morning. And I would reset her to no more than 0.1 to 0.2 units per kilogram, even though I believe 0.3 is probably a good amount of basal for her. So you can see here what her current regimen is, and I actually think this is a good regimen, but she's scared right now, so we have to do something else, right? And so I would reduce her to, like I said, 0.2 units to 18 units, and then maybe just start her at 5 units with meals and continue her empagliflozin, and then see how she does. And I'm going to ask Faiza just briefly to talk about, adding back our preferred GLP-1s and what we can do to better support her so hopefully we can get her off of insulin.
Really. So she was on exenatide extended release previously, which was self-discontinued for unclear reasons. So what other options do we have for GLP-1 coverage? She has insurance through Medicaid, and the preferred GLP-1s with Apple Health or Medicaid are liraglutide, exenatide, immediate release, or exenatide extended release. What if we wanted to use one of the newer weekly agents? So here is the Apple Health Medicaid coverage criteria for adults who have type 2 diabetes without established cardiovascular disease or multiple risk factors. They need to have a documented A1C greater than or equal to 6.5%, history of trial and failure to metformin, a preferred SGLT2 inhibitor, and one of the formulary GLP-1s. So our patient, actually meets all these criteria, and with a prior authorization, we could get coverage for a newer, more potent weekly GLP-1 like injectable semaglutide or the dual GLP-1 GIP receptor agonist tirzepatide.
Yeah.
For adult patients with type 2 diabetes who have established cardiovascular disease or multiple risk factors, the criteria is slightly different. They need to have a documented A1C greater than or equal to 6.5% and history of trial and failure to a preferred SGLT2 inhibitor and liraglutide.
And so in summary, I think what we want to do is try to maximize her insulin sparing agents and minimize her insulin. And so I would continue her on the empagliflozin at 10 milligrams. I'd really push her to consider trying the metformin, and I would use a 750 milligram tablet extended release just to make it easy right before breakfast once a day, and then in 10 to 15 days increase it to the goal of 1500, and she could do 2 tablets of that in the morning or 1 twice a day, whatever her comfort level is. And you might be able to sell it as it's a reduced dose, but you really get an effective dose at 1500 milligrams. So sometimes that does support the person. And then if she wasn't intolerant to Bydureon, most commonly I'll document people get these skin nodules from the needle. And so I'll just document that they're getting these skin nodules, and then that makes them, not eligible for it. Or if she's having a lot of reflux GERD symptoms, we can also document a treatment failure for that reason. And then because of her history of GERD, I might lean towards starting tirzepatide if we can get it, because I have found in our population the GIP, GLP has slightly less GI side effects, especially if we heard that the Bydureon did cause worsening of her GI effects. But either one, the tirzepatide or the semaglutide at a low starting dose would be preferential for me. And then I might, when we add the tirzepatide and semaglutide, do no basal insulin, just with the metformin SGLT2 and the low dose of tirzepatide, and let her blood sugars run a little higher. Or you could, I would be very comfortable doing 0.1 to 0.2 units per kilogram. So somewhere between 15 and 20 units of basal insulin would probably be a safe dose for her. But again, we might be able to sell to her, let's do all insulin sparing agents so your risk of hypoglycemia is very low. And then once we get to the maximum tolerated GIP, GLP, or GLP receptor agonist, we will add back the insulin if needed. And so again, this would be my preferred titration once a month. Increase metformin and empagliflozin, and then plus minus on the glargine. And I would simply say to reduce the dose every time she went up on the tirzepatide by 5 units, and or if her blood sugars were running in the low 100s. And once she got down to 10 units, I would have a low threshold just to hold it and to monitor it, because again, what we don't want to do is promote any hypoglycemia. We can always add the insulin back. So, in summary, our goal for her is not to be an A1C of 6.5 to 7. It's probably less than 8 right now without hypoglycemia. And then once we are not seeing her fears of hypoglycemia or that relative change in blood sugar, we can reset her goal. Really strongly push the metformin, empagliflozin, using that weekly insulin sparing injectable and a low dose basal insulin. And then, the final thing is I'd really compliment her on using that protein component snack at bedtime and seeing if she can incorporate a little bit more healthy protein up front with her meal. So thank you very much for your time. This ends session 6 of the Cardiometabolic Echo.